صباح الخير حنان.
صباح الخير يا حنان، تسمعوا صوتي؟
صباح الخير.
أنا مش سامع أي حد فيكم. صباح الخير يا دكتور حيدر.
صباح النور، أهلا ومرحبا.
أيوة.
صباح الخير دكتور، كيف الحال؟
صباح النور، أهلا ومرحبا. الحمد لله.
صباح الخير يا حنان، إزيك؟
أهلا أحمد، كيفك؟ شو أخبارك؟
الحمد لله الحمد لله.
كيف رمضان؟
الحمد لله. عندنا عاصفة ترابية طوز الحين موجود بالكويت.
يلا الله يبين.
الله
عندنا
كريم.
مطر.
خير إن شاء الله، كله خير إن شاء الله.
Hello Murat, nasılsın?
Günaydın Murat.
Doctor, do you want to start or we wait 3 minutes?
Better to wait for 3 minutes.
Wait 3 minutes, okay.
At the official time of 11.
Okay. How is the weather in Baghdad? Good?
Start to be hot.
Oh.
I can see that your clothes is still of that of winter. بس احنا بغداد بلش بينا الحر يعني حقيقة. أول مرة نفرح بالحر. أول مرة نفرح بالحر، نقول بركة
عشان الكورونا.
كورونا، نقول بركة. ويمكن احنا مثل الكويت هماتي منتظرين عاصفة رملية احتمال راح تيجي على بغداد. هي الكويت وبغداد قريبات، يمكن الأنواع الجوية يعني اكو احتمالية عاصفة رملية قريبة جاية على العراق. والله يستر.
Murat, günaydın.
Alo Handan.
Nasılsın?
Sağ ol, iyiyim. Sen nasılsın?
İyiyim. Nasıl Türkiye? Korona ile.
Korona ile of.
Ya çok. Ha?
Sen nasıl? Çocuk nasıl? Annen nasıl?
Hepsi iyi. Elhamdülillah,
İyi.
çok şükür yani iyi.
Çok şükür, çok şükür.
Wow, Hanan, nice talent. You speak multiple languages.
No, Turkish is a little bit, not too much. Good, not too much.
But it's good anyway. To know something better than me that I know nothing about Turkish language.
I live in Turkey 2 years.
Oh, really?
I work, yes, the hearing aid manufacturer in Istanbul.
Nice, nice. Which company?
Ear Technique.
Very nice. Seems good. We have less than 1 minute and
Is it mute now? No.
Hanan, can you see the startup of the presentation on the screen?
Yes.
Seems good.
So do you want to mute everybody and we start?
Yeah, we will start right now. Hello, everyone. Very nice to meet again with the new webinar about severe and profound hearing loss. I'd like to say hello to everyone. We just returned back to our office in Baghdad, so I'm conducting this webinar from the office now. Hope that all the world will remain okay and everyone return to normal life, return to work, return to everything. Yeah, I mute all the audience now. As we know, I'm Haidar Sarhan from College of Medicine, Mustansriya University. And I'm doing hearing test with Pat Centero since more than 3 years. But I was doing the hearing test with other devices from other manufacturers for a very long period of time of my life. So as usual, I already mute all the audience, and I hope that anyone that at any point, at any moment of the webinar have any question, just write it immediately on the chat. Also, I hope that if you can write your email, so if we don't have time to reach all the questions, we can write emails to you. And if you, for audience who don't have questions, but they are interested to know the answers of the questions from other audience, they can also write email, and they will be welcome, of course. That's what we usually use to during the webinars, and hopefully this webinar will be beneficial to all the audience. Yes, I see that some people are joining, and I want to join all before the start up. Yes, okay. Now, presentation of the child with severe and profound hearing loss. In fact, the idea, the principle, and the goal is to identify the patient as soon as possible. Is to diagnose the patient with hearing loss, the child with hearing loss, as soon as possible. For that, a lot of countries implement a program of hearing screening. So in those countries with neonatal hearing screening, the presentation will be very early of life, because those infants, usually neonates and infants, usually will have a refer screening test. So the presentation is usually by very early during life by the hearing screening program. But in countries where there is no hearing screening for the neonates, just like in our situation in Iraq, usually the parents recognize the infant does not react to the usual sound in the first year of life. So usually there will be late presentation. And that's the goal of hearing screening, is to identify the patient as early as possible. Yes. Now, sometimes the child being diagnosed by a good suspicion from the otolaryngologist or pediatrician. Why? Because, for example, otolaryngologist examine an infant and he finds some congenital deficit in the external or middle ear or external canal, and he can think about the presence of anomalies in the internal ear, and he start to check everything, and he discovered the problem. Also, the pediatrician sometimes find another problem in the thyroid gland. There will be the child have, for example, the infant have goiter or have a problem in the renal system, and we know very well. For example, we have Pandart syndrome, where the child usually presented with sensory neural hearing loss and with congenital goiter. So the pediatrician, when identify the goiter, he start to send the baby for hearing test and confirm the presence of sensory neural hearing loss and the diagnosis of Pandart syndrome being confirmed. Also, we have Albert syndrome. For example, the pediatrician identifies some congenital anomaly in the renal system, and then he also start to search more features about this syndrome and identify that this child has sensory neural hearing loss, and the diagnosis is confirmed. although in case of Albert syndrome, sometimes the sensorineural hearing loss delayed to late childhood. And also we have Nichelle aplesia, which is total congenital total absence of the internal ear of the cochlea, and we have Mandini malformation. And we have a lot of malformation, congenital malformation, like in CT scan, if we find enlarged vestibular aqueduct and a lot of findings that suggest the presence of sensorineural hearing loss. All of these categories makes the diagnosis possible by the good rate of suspicion from the otolaryngologist or the pediatrician. Anyway, the hearing screening system, the role is to identify the hearing loss and treat it as soon as possible. Now, I want to return back to this table that already presented in the last lecture. As we can see, in case of severe hearing loss, the child may detect loud sounds in the environment, but will not hear normal conversational speech. What that means? That means that usually the parents bring the child and say, okay, this child only responds to shouting. When we shout behind the child, he turns the head. But he cannot respond to conversational speech. And if we see the profound hearing loss, child likely respond to vibration rather than sounds. And usually the parents in that case bring the infant and mention that, for example, the child never respond to sounds, but respond only to sound of vigorous closure of the door, for example. And for that, as you know, vigorous closure of the door is the child will respond to vibration of the closure of the door rather than to hearing. That's the usual story of children with profound hearing loss. Yes, recommendation, I recommend that we test the cochlear function for all the children, and we test the neural function for all the infants, and we perform frequency-specific tests. All these things have been mentioned in the last lecture, and I want to repeat and repeat and repeat because it's very important. Cochlear function, neural function is very important, and frequency-specific test is very important. So I want to repeat very important things. And also, always it is good to check the middle ear. Middle ear problem, normal, when we have middle ear problem and normal cochlea and neural connection, there will never be severe or profound hearing loss. That if some audiologist is being with us, as all of us know, audiologists know that very well. And if we remove the function of the middle ear totally, if we remove the function of the middle ear totally, we will have moderate or maybe moderately severe hearing loss. We'll never be able to have severe or profound hearing loss. That's the point. Why? Because when we have severe or profound hearing loss, usually we have cochlear deficit, because the total amplification of the middle ear will never reach the deficit of the severe or profound hearing loss. So when we have severe or profound hearing loss, usually we have cochlear deficit. Maybe there we have also middle ear problem, but usually we have cochlear deficit. So tympanometry is good. Tympanometry is good habit to perform, but tympanometry usually detects very sensitive for detection of middle ear fusion, which is usually the most common cause of conductive hearing loss in children, but it is acquired problem. It is not a congenital problem. Now, in this webinar, we are focusing on congenital anomalies of the ear. Unfortunately, the congenital anomalies of the middle ear, like, for example, ankylostevidial joint fixation, congenital ankylostevidial joint fixation, the tympanometry will be not useful. The other bad news that if we bone conduction ABR needed in moderately severe or moderate hearing loss. And to do bone conduction ABR is not useful when wave 5 detected at 80 decibel or higher intensity level. Why? I will tell you. Because any device in the world, any ABR device in the world, any pure tone audiometry in the world, there is a limit for bone conduction. There is a limit for bone conduction. And the limit for ABR bone conduction in any device in the world is 60 decibel. What that means? That means, for example, if we have an infant with wave 5 detected by ABR at 90 decibel, and we think that we have some problem in the middle ear, and we think that we have airborne gap of like 15. If the wave 5 being detected at 90 and we want to confirm that there is airborne gap, we should identify wave 5 by bone conduction at level of 75, which is impossible because the limit of all devices of the world for bone conduction ABR is 60. So this is that's the bad news of the doing bone conduction ABR. Bone conduction is very great when we identify the level of hearing about moderate or moderately severe or mild hearing loss. We can identify the airborne gap correctly with the ABR, but if we have severe and profound hearing loss, we cannot identify the presence of airborne gap. For that, we should, if we suspect a patient with congenital middle ear problem, which is usually combined inner ear anomalies, we should send the patient for radiology. We should send the infant for CT scan, and we can identify the state of middle ear function in a very good way by radiological examination, of course. Now, let's start with identifying some examples. We have a 3-year-old child presented to me with hearing loss and delayed speech. And this is one of the most important problem when we have lack of neonatal hearing screening. Sometimes the parents are ignorant. And the child reached 3 years without diagnosis, without management, and definitely this child with 3 years, the development of his speech will be affected. The development of speech will be delayed. And that's the principle of neonatal hearing screening. We should detect the presence of sensory neural hearing loss, especially moderate, severe, or profound hearing loss, as early as possible to prevent further complication. This child presented at 3 years of age, which is very delayed. And as we can see, we have distortion product autoacoustic emission screening test refer on the left and the right side, and also the transient autoacoustic emission referred on the left and the right side. And we can identify wave 5 being detected at 85 in the left and right side, and repeatable in both sides, repeatable 85 with similar morphology, with similar time latency. The threshold is 85 in that case. And I performed for this child, I performed ASSR, and you can see the result of ASSR. And it is very important with this example to identify the importance of frequency specific test. Now, if your device has only ABR and you want to manage this child, you will go for fitting a hearing aid at level of 80, linear 80. And definitely the child will have distortion, because this is higher amplification level. Will have a good distortion from the hearing aid because it is not fitted according to frequency specific test, and the acceptance of the child for the hearing aid definitely will be very bad. The child will be reluctant to wear the hearing aid, and definitely the overall management will be bad. The reverse story is totally true. When we have ASSR, we have a frequency specific test, and we program our hearing aid according to the frequency pattern. By the result of ASSR, definitely the distortion will be less, and the acceptance rate of the child of hearing aid will be more. the reverse is true. In that case, I have a lot of stories that the child starts to love his hearing aid. The parents, they say that the child, when wake up at morning, he just want to have pairs of hearing aids, and he will cry if, for example, they don't have batteries or something like that. They come to the office and they want to solve the problem of the hearing aid because the child loves the hearing aid. And of course, he loves to listen to the environmental sound. He loves to learn speech with a speech therapist, and overall process will be successful. Yes. So that's the importance of frequencies, of performing frequency-specific tests. I advise all the operators to perform frequency-specific tests, and also to confirm the threshold by 2 tests. Now, I've confirmed the threshold by ASSR and by ABR as well, chair signal ABR. So outcome of that child, that the child respond very well to hearing aid amplification and speech therapy. And now this story was something like 3-4 years before, and child now attending school and everything is fine. Let's go to example number 2. 1-year infant presented with hearing loss. I performed the screening test, the distortion product, autoacoustic emission, refer left and right side, the transient autoacoustic emission, refer left and right side. As you can see, ABR, chirp signal ABR, there is no wave up to 95 decibel. There is no wave up to 95 decibel. Then I performed ASSR, and as you can see, we have only responses at lower frequencies with no ASSR response at higher frequency levels. The outcome, this child get no benefit from hearing aids amplification for 1 year. And at the age of 2 years, cochlear implantation performed, and then cochlear implantation with a speech therapy was successful. And this child doing well with cochlear implantation. Okay. So usually we should keep the child on a trial period of 6 months to 1 year before going to decision of cochlear implantation, whatever the result of our hearing test. Even if it is profound, we should wait for the trial of hearing aid. Now, case number 3, also 1-year baby presented with hearing loss. Now, again, the screening test of distortion product autoacoustic emission, refer left and right side. Transient evoked autoacoustic emission is refer left and right side. And when I perform the screening test, I just perform autoacoustic emission to perform test of cochlear function, as you know, while ABR is a test of the neural function. And now, ABR, there is no wave 5 up to highest intensity level of ABR, which is 95 decibel. And we have also no ASSR responses at all frequencies in both 2 sides. This is the typical example. This is the typical example of Michel aplesia, total malformation, total absence, total congenital absence of the cochlea, both 2 sides. So really, if there is no ASSR responses, if there is no ASSR responses at all frequencies, both 2 ears, and there is high suspicion of congenital absence of the cochlea, and we should send the patient for CT scan to identify presence or confirm absence of the cochlea, and the diagnosis of Michel aplesia is confirmed. I see one of the audience raise hands. Please, let's keep it, because we have limited time. Let's keep questions immediately after presentation, and I promise you that the presentation today will be not so long, so we can have time after finishing presentation. Yeah. No. So this is, as I mentioned, this is the usual presentation of Michel aplesia. Now, management, as a rule, early detection and interference is very important, and is our goal in treating patients with severe and profound hearing loss. And also threshold estimation should be confirmed by two tests. Threshold estimation should be confirmed by two tests. As a rule, and as a rule of management, I want to summarize the management. In fact, as a rule of management, when we are able to recognize wave 5, hearing aids will be beneficial. For example, this is a very simple principle. For example, if you get wave 5 even at 90 decibel, you should think that in your mind that hearing aid will be beneficial for that child. Why? Because simply what's the hearing aids doing? Hearing aids is amplifying sound according to special equation, according to hearing test. It will amplify the sound. So if we are amplifying the sound, we want to get like effective hearing. That's hearing with good neural stimulation and that's simply when we are giving, for example, 90 decibel, very high intensity sound level. It is a loud sound, and we get wave 5. That means that we get the neural stimulation for that loud sound. That's good news. That means that this child, if we get the same intensity level, same high level of sound by amplification, by proper amplification, by hearing aid, will get effective neural stimulation, and we get effective hearing, and we can continue our life with hearing aid. So as a rule, when we have wave 5 detected at any intensity level, hearing aid will be beneficial. If there is no wave 5 and there is ASSR response, we should think about cochlear implantation. This is not a rule, because I have a lot of patients that they don't have wave 5, and I have only ASSR responses, and our team, of course, we fit hearing aids for according to ASSR, frequency specific ASSR results, and the amplification was successful for those children. But anyway, if we don't have wave 5, and we have only SSR responses, we should think about cochlear implantation. We should talk with the parents about possibility of cochlear implantation. Usually, I tell the parents that we will perform hearing aids amplification, and hopefully the hearing aid would be beneficial, in most of the cases beneficial. But if we are unlucky with the hearing aids, we should perform surgery of cochlear implantation. And when we don't have wave 5, we should keep in our mind cochlear implantation as a rule. Of course, after trial of hearing aid, which is in our story in most of the cases is beneficial. Now, as a rule, if there is no wave 5 by ABR, and if there is no ASSR responses, and there is absence of the cochlea being confirmed by CT scan, this is typical feature of Michel aplesia. This is typical example of Michel aplesia. In that case, hearing aid amplification is unbeneficial. Cochlear implantation is contraindicated, and we should think about brainstem implantation as a possible solution for that cases. Brainstem implantation, I don't know which countries. In Iraq, we don't perform this form of surgery. I don't know the audience situation. They have in their healthcare system this form of surgery or no, but I know it is limited to few countries. It is performed in Germany, it's performed in US, other countries I'm not sure in fact. But in Iraq, no, we don't perform brainstem implants as a solution. Now, yes. Why frequency specific test is just being mentioned for best hearing aid amplification, for amplification of hearing aid without distortion. If we have hearing aid, if we want to perform hearing test without distortion, we should perform frequency-specific tests. We should have, for example, ASS on our device. And for better cochlear implantation selection, this is very important point, because nowadays we have two types. In fact, many types of cochlear implantation, but we have, in general, let's classify it to conventional cochlear implantation and hybrid cochlear implantation. Please look to this diagram. This diagram very beneficial. As you can see, in this area of frequencies and intensities, conventional hearing aid is usually beneficial. When we have this area, conventional cochlear implant would be beneficial. But when we have ski sloping hearing loss, I think that most of you know what ski sloping hearing loss. It is high frequency hearing loss. It is high frequency drop in the pure tone or in the hearing test result, a frequency specific result. I will mute all again. Yes. When we have such form of hearing test, when we have ski sloping hearing loss, the best is to have hybrid system. Available and implant the patient with hybrid cochlear implant. What hybrid system will perform? Hybrid system will have a short electrode wire implanted in the basal turn of the cochlea, so it will make electrical stimulation of higher frequency in which the hearing loss is profound, and it will keep hearing amplification, just like what hearing aid doing for lower frequency. So it is hybrid system between electrical stimulation and hearing amplification. So for that, it's called hybrid cochlear implant system. And this is very beneficial for ski sloping hearing loss, high frequency drop hearing loss. If we don't have frequency specific test, we will never ever be able to select this form of cochlear implantation. So that's another very important use of frequency-specific tests for those category of patients. Now, why testing cochlear function in severe and profound hearing loss? Again, to exclude cases of auditory neuropathy. And I demonstrate this case in the last lecture. In auditory neuropathy, usually the cochlear function, we should test cochlear functions usually present, like autoacoustic emission or cochlear microphonics, with abnormal neural function like ABR. So for that, it is very important to perform a cochlear function test, even in cases of profound or severe hearing loss. I hope that all of you return to your work, return to your life, but even if you return to your life and work, be safe from coronavirus. Keep your personal protective devices. This is me. This is my picture when I'm doing the test of the patients in my clinic at that time. Hope all of you are in good health, and thank you very much for your presence and your listening to this lecture. Thank you very much. Now I can, Hanan, I just finished.
Yes, I can hear you, doctor.
Okay, so I will mute all again, and if anyone have a question, he can like write it down. Yes, I mute all again. If anyone have a question, do you have? Is there any question, Hanan, in the chat room?
Yes, there is. You can have from Dr. Habib Suhaib.
Yes.
He mentioned something like electroacoustic stimulation, and then he asked what's your experiencing in managing auditory neuropathy cases?
Okay, for auditory neuropathy, we should try hearing aid amplification, but in lower intensity level. For example, if you don't get wave 5, and in that case you think that a neural threshold of hearing is around 95 decibel or more, 100 decibel. You should amplify this child with less intensity level. For example, you should amplify the child with 50 decibel, and keep observing. Of course, you should give some medication to improve neural function, and you should keep your eye on your patient for close follow-up for those children. Because it is something that sometimes if you don't keep your eye on your patient, the state of auditory neuropathy will change to classical sensory neural deficit. So amplification for auditory stimulation by amplification is very important in that cases, and keep your eye on your patient, and keep follow up this patient. Also give medications to improve the neural functions. That's auditory nerve tonics. Yes, other question? Hanan?
Yes. Have you done any research to compare ABR results and ASSR thresholds? And how much can you trust in ASSR results for fitting hearing aids?
No, ASSR for fitting hearing aid is a standard in case of severe and profound hearing loss, because there is no other way. Even frequency-specific ABR will give us like low frequency and high frequency. And when you are fitting hearing aid, you need 4 frequencies for better fitting of the hearing aids. For that, use ASSR is a standard. In fact, is a standard. For research, I have only research for mild and normal hearing comparison of ASSR with ABR, but for me as a personal research. But there are, if you search the Google Scholar, for example, or any other learning station, you can find a lot of researches of comparison, and usually ASSR is the conclusion that usually ASSR is trustful. You can't trust ASSR results. Yes, Hanan. Hanan.
Yes, I think this is the questions we have for this lecture.
Yes.
If anybody has another question, yes, please.
If anyone of the participants, because it is great. I see we have like 57
75.
And if anyone want to ask directly, just unmute and you can ask. I can listen to the question. So it seems that's great. Today we finished everything. We finished also the questions without in the time, because we have only 1 minute now, and I hope all the good for all of you, and I hope also this is good that I have 1 minute to say thanks for your attendance for all of you. Thanks for your time, and also I would like to say keep safe from this virus. Hope to return to your life gradually, and thanks a lot for all of you. Thank you, Hanan.
Thank you, doctor. Thank you very much.
Thank you very much
for the lecture. Yeah.
Thank you very much. Bye.
Bye. Bye.